So I Toka. I want to get it right. Toka. Toka's the thing. Yeah. Okay. That works. Are we good? Are we on? Hi everyone. Welcome back to the main stage at Giant. We had a great morning, of course, with the whole kind of 5G and healthcare and connectivity from all parts of the world. We had speakers from Europe, from Scandinavia, Scotland, Ireland, also the UK. So we really talked about how we connect things going forward, where the role of industry comes into healthcare, the partnerships they've created, and how they've helped during COVID pandemic around predicting disease or the ability for hospitals to manage intensive care better using connected data. So I found that really useful. What of course it meant is that these industry partners were helping us solve some of those big challenges, I guess, in healthcare. And our next panel is all about those big challenges. They're going to, in 1 hour, solve all the problems we all try and solve for many, many decades, I'm told. And we have so many experts around that. That's for an hour. and we'll do some Q&As at the end, of course, and please feel free to ask questions and get them ready during the session. At the end of that, we'll have a demo from Alertive around their communications platform. So do stay around for that and see how it all works. I think the whole world of comms is changing going forward. It's been an agenda on NHSX, NHS Digital, on how do we get rid of pages, as I'm sure Kevin will tell you all about during the conversation. How do we move on to more modern methods of connecting and communicating with people? And after that, there'll be some networking session. So hopefully you'd hang around for us and hopefully you'd carry networking with us prior to finishing this evening. So I'm going to hand over to Matt Rule, who's CEO and founder of Toka.ai. Is that right? I got it right. Okay. Matt, it's all yours.
Here you go. I'm going to go over this. Hello, everyone. Can everyone hear us okay? And thank you for joining us for this debate on navigating interoperability. My name is Mark Chillingworth, and I've been writing about CIOs and CTOs for about 12 or 13 years now, so it's a great pleasure to be moderating this panel debate. And connecting care is vital if health services are to reduce waiting lists and remain efficient. But connecting care is about more than just the hospital setting. The complexity and continued care demands, and the debate earlier talked about the challenges of social care, are going to require an emphasis on sharing information that will enable care. And this has become a high point of interest recently, probably long overdue. But to connect care, information and technology needed to underpin that must work together seamlessly. So we're going to discuss that and how that is a reality, but also some of the challenges in this debate. And so my guests are, for this panel debate, Matt Rule, CEO of Toka, Kevin McDonald, CEO of Datala, and Dr. James Samuru, host of the Health Tech podcast and founder of Somex. Is that correct? So, gentlemen, thank you for joining me. As Xavi said, this is a welcoming fireside chat, so please do, if you've got things you'd like to raise, I'm all up for just having you raise a hand and get involved and make this a very interactive and discursive session. But I'll kick proceedings off. So first of all, to set the scene, I guess, is why is connecting health and healthcare systems back in vogue and so important at present? Matt, I'll start with you if I may.
Thank you. I'm just checking I've got my mic right. I've thought about this a lot, and it's not just in healthcare. I mean, it sits across industry ultimately. It's not just the pandemic. We know the pandemic's accelerated a lot of technology adoption. But even before that, with the likes of, IBM Watson, some of the AI drive and that revived interest in AI. And it's possibly to do with, across businesses, consumers have got higher expectations ultimately of how they engage with businesses, but also that applies to healthcare and trust as well. And I think those pressures, those expectations are starting to be put onto businesses, but also then expectations put onto trusts. If you want to book an appointment, you don't want to have to ring up, sit on the phone for 45 minutes to get through to a receptionist. You want to be able to do that on your phone. You want to see what appointments are available. It's probably as simple as that. But it's
seamless word, isn't it?
Yeah, and I think that's probably driving a lot of this. I think then as those pressures start to push in on the trust, and if we were talking about limited companies, as those pressures come on the LTD or the LLP, the company's got to respond in order to be competitive. And within the NHS, it's probably not competition, it's more around patient outcomes and expectations there. So it's probably something to do with that.
Yeah. Thank you. James, what do you see as to why this is back in the agenda?
I think it's down to something that Matt mentioned there about expectation. I think when I was a practicing clinician, there wasn't the same expectation that there is now for everything to be seamless, as you said. The idea of writing blood test results in one place and then another, and then communicating them to somebody else, and then them writing them somewhere, and then them getting scanned in somewhere, and then you've got to find them for the discharge summary. All of that was completely normal. And you were annoyed by it, and you knew there were greater ways. If you thought like I did, you knew there were efficiencies to have. But I think now the expectation based on what people are doing in their personal lives, everything is done on the supercomputer in your pocket. And so there is just this huge pressure for technology now to catch up, particularly somewhere like healthcare. So for clinicians to have a life where everything is far more seamless and makes so much more sense, their productivity, their efficiency, and everything else is so much more, that pressure falls down into the day job in the hospital now. And I think that's where this comes from, the expectation and the knowledge and the belief that things can be better, they need to be better, they should be better. So interoperability should be happening very soon. That's how I feel.
Last but not least, Kevin, what do you see?
So can you hear me? Excellent. So interoperability has been a challenge for decades. With the increase in digital tools, I think we've made the problem worse because there's valuable data sitting in silos at a greater level than ever before. So if we're going to take advantage of all that valuable data to make better decisions quicker and faster for the benefit of patients, we need to be able to access them regardless of the tools they sit in and the care setting that they were generated from.
Wonderful. So having set the scene and sort of given us sort of a definition of interoperability, could you maybe introduce yourselves and your organizations and sort of where you are in your storyline as to what interoperability means to you in your lives? I'll start with you, James, and move that way along the panel.
Sure. So hello, everybody. My name's James. I'm an anaesthetics IT doctor by background, which I alluded to. I practiced clinically for 5 years. I've done lots of different things in leadership, policy, innovation in the NHS. So I've worked at NHS England, at Health Education England, at the BMJ. I've run 2 different health tech accelerators. And the other side of my life has always been more media stuff. So I write for Forbes on health tech as a contributor. I host the Health Tech podcast, which goes out around the world. And I've also got Health Tech Pigeon, the newsletter, which goes out around the world, which is going to be an online publication next year. So in terms of interoperability and what it means to me, I think about this from being a practicing clinician and that frustration that I had that nothing talked to each other and I had to do everything so many times. So for me, interoperability means doing something once and it means everything is connected. And I approach that from being a clinician. So I imagine it means very different things to technologists. But for me, it's doing my job well enough as a clinician, as a ground floor healthcare worker, being given the best chance to do that by all the systems working well together.
James.
I'll go again.
I'm so good, do it twice.
What am I? I'm a frustrated engineer, I think is. I worked as a telecoms engineer and then a managing consultant, and I worked across private and public sectors. I guess there's 2 angles. I'm sympathetic to the complexities within business, and I understand, you can't just have a green field and we can't just bring in the latest tech, or we can't just buy this system and solve problems. I understand that. But then there is a part of me which is very much frustrated that we overcomplicate what I think is quite simple sometimes from an engineering point of view. And I founded Toka. We founded around about 2018. We started, we're going to talk about no code today, but no code wasn't a term when we started. What we were trying to do is build a system that would allow you to automate platforms, automate anything, and be able to build interfaces for people, humans, which is a bit of an unusual term to use, but we'll go with it. We are them. And by having interfaces for people, building automation platforms at back end, you can systemize processes really quickly. And if you can do that without having to write code, so that the vast majority of us can get involved in it, then you can start to affect change really quickly. And so that's what our company does. That's what we're about.
Brilliant. I'll get your name right. Kevin, tell us about yourself and your interoperability journey.
Yeah, so Hello. Okay.
It is now, yeah.
So I started off as a biochemist a very long time ago before moving into technology. and was a technologist for 10 years before moving into health tech. And in health tech, I've been a founder, operator, and CEO. And I've built businesses and sold them and worked for big organizations. And what I do today is try and share some of those bruises and scars with others. So Daytana is a consulting firm. And apart from that type of work, I'm a portfolio director sitting on the boards of several companies, trying to help people navigate the journey of getting technology built, deployed, used, and adding value in healthcare systems around the world.
Thank you. Two of you mentioned the importance of making life easier for clinicians. Therefore, to make interoperability work, we need to get them involved in the development process. How do we do that? I'll start at the engineering and then we'll move more towards the clinical end.
So I guess, as well as founding a company, we sell our products into a number of NHS trusts and a number of organisations, and particularly a trust I was working with and talking to recently. They're doing a big EPR rollout. And what's interesting is not only do these systems cost a huge amount of money, they occupy a huge amount of that trust and that organisation, including clinicians, which always seems to come as a shock. And I think we've got something wrong there ultimately within how those things are deployed. Where we're working, we try to work as closely with clinicians, get clinicians to, particularly in things like cancer pathways and where you've got MDT and MDT teams, and try to get the process out of the clinicians. One of my team coined it unconscious competence. And particularly in cancer, where the trust that we're working with are dealing with 1,600 patients at any one time, and you've got clinicians who are trying to manage those patients and work out where they are in the cycle, it's complicated. You need to systemize that so that the clinician can think clearly and isn't actually having to piece together a picture of what needs to be done. So trying to get those processes out of the clinicians is hard, but and we'll probably come on to this a little bit more, the value of what we then get, the process that we can arrive at, the system that we can build, whatever it is we pull together with them, seems to be a lot more valuable. We seem to get a lot better feedback than if it's
co-design.
And so it seems to be a hell of a lot more valuable. Yeah. But there's a few extra points there I'll come on to later.
I think it's not underestimating that as well. I think what Matt's described there is, appropriate resource actually dedicated to it as part of the journey of adoption or even design. I think a lot of, you ask anybody, any entrepreneur, anybody building a health tech company, do you think clinicians should be involved in this? Yeah, everyone's gonna say yes. But what's the actual practicality of that? Because you could get a clinical director to come in and give some very high level, this looks about right for my juniors and all the rest of it. But are you going to get every single person part of that MDT in oncology, the occupational therapist, the physiotherapist, the junior doctor, the senior registrar, the consultant? Every single one of those has a view of that process. Every single one of those has a stake. They are all going to benefit from something being slightly different. And so to think that you can design a process outside that MDT is ludicrous. Something that's going to be optimal, something that's going to work perfectly. I think that's the ambition we need. We need to aim for perfect, because anybody that's worked in healthcare will have used systems that are so far from imperfect, designed by people that aren't the users or all the rest of it. But anyway, I think it's about, from the company side, putting appropriate resource into finding out the answers to those questions and being incredibly granular and practical about the whole thing.
Kevin, any experiences you share?
Yeah, absolutely. I think involving the clinicians in the process is absolutely critical. You can't decide what they want and then try and deliver it to them without getting them involved. And there is a difference between wants and needs. And often a entrepreneur or technology company will design what the future looks like and get frustrated that no one wants it. That's because no one has the time. What they need, bizarrely, is a want. And actually, we should be giving them the wants now and going on a longer term journey to give them the need for the future.
It has to be a team effort as well, because I think in part, clinicians don't often know what is possible. They don't believe that it can actually be better. And so it needs the paradigm of an engineer or a computer scientist or a data scientist or all of the above to actually show people what is possible, to then spark that in their minds that they can then help you design. I mean, you must have seen that in the work that you've done. Yeah. There must be a light bulb moment where all of a sudden all of those things come together and the person starts believing that something new is possible.
The one thing I observed, which was different in the NHS than in private sector, is there's less moaning about the system, about the poor system that's been brought in and put in place. There's more of a let's just get on with it. We've got a job to do, particularly from the clinical point of view, and that's a shame because it could be done so much better. And so we're still learning about it as a company and working out how we can support the trusts better, because obviously occupying the clinicians for a period of time trying to get these processes out is hard, and it's also occupies a load of their time. So we're not perfect. We're trying to get that right, but I think the outcome is far better. And we'll talk a bit about how our system and our ethos supports that. But it does involve clinician partners and also the CIO level and the CIO teams ultimately within the trust as well to deploy this technology in the right way.
And on that point, and you touched on it right at the beginning, James, is some of that a cultural change? One CIO mentioned to me recently that she's got a workforce now that effectively have had very little experience of paper as the new generations come in, and you talked about the expectations change. So is an interoperability almost cultural now that actually as the culture of health is changing, so interoperability has to move up the agenda? Kevin, can I start with you on that?
So I think the biggest hurdle to interoperability is organizational readiness and a cultural appetite to change. I don't actually think it's about technology. Technology's been there for decades. It's actually getting people to pause for a sufficiently long enough period of time to realize what the value of interoperability will bring them tomorrow.
Very good point. James, anything you'd add on that sort of cultural change?
I think it depends who the stakeholder is, right? I think Kevin's right. It needs to be right through an organization that they need to be ready for it. I think in the companies that we've helped through Sonex, which is the communications agency that I have, I've seen that done well when those companies, those health tech startups, those technologists have found those organizations willing to change, that the organizations have done that bit of the journey alone, and then they start to look outwards more. I think it becomes a heck of a lot more difficult when you're trying to create the market and then sell into it. So you're trying to show them the problem and the solution at the same time. I think once people have identified that problem, and yes, I think culturally that is happening, certainly. There's a lot more readiness to change. So yeah, I would say we're on that journey, I think, from the big organization.
Is there anything you see, Matt?
So I was listening to some podcasts around, as well as yours.
Thanks.
Yeah, you're welcome. Around how things are going in America, and obviously it's slightly different. And I can't remember the podcast, but they were talking about patients owning their own data. I'm not sure I want to own all my own medical data. I'm not sure where I'm going to put it. Top drawer beside my bed is already full. So I think it's always going to be owned by the people that use that data. But I guess what they're talking about is access to it. And obviously, America's slightly different and it's more transient than in the UK. I think there is an expectation, and we can see it already. I can see it with the younger members at TOCA, how they interact with systems, what their expectations are. So I think we're yet to see how that's going to affect healthcare, in the UK. I would say that I think the people like NHSX are doing a great job, and I think they need to start to lay the foundations for a much more breathable NHS. So instead of going in, spending tens of millions of pounds on huge IT systems that are quite static and rigid within an organisation, it's time to start to allow your organisation to breathe. It was the NHSX guy yesterday, sorry to name him, I'm not going to quote him directly, but he talked about hidden technology. And it rung true, because I've often thought about invisible tech and technology that supports what you're looking to do. It's not paper-based process. It's not having to get on the phone. It's about being able to get the answer there and then in the supercomputer in your pocket. And I think that's only going to get worse. Those expectations and pressures on how the NHS provides its services is going to it's going to get more intense, and that includes private healthcare. It includes all organisations ultimately.
Yeah.
I think we also need to recognise that what we expect patients to want is probably different from what patients expect is already here. So, it's 5 or 6 years ago, but we surveyed, 10,000 of our patients about fundamentally interoperability. What data do you think we have access to? And 80% of them thought we already had access to all of the data about them across all the systems, whether it be primary, social, or secondary care. So patients want, if that one survey is indicative of market need, patients already expect us to have all the answers.
Moving on from the cultural piece, many of the healthcare organisations here today will have a number of systems, a number of care pathways we've got to deliver, systems that match certain pathways. Rather than interoperability, should they just be consolidating and shrinking the technology estate and simplifying the organisation? Which, of course, is a very nice, simple question for a journalist to ask. Kevin, if you...
I think we tried that before, didn't we?
Matt?
Well, I'm looking at this across industry. I think there's pros and cons, if I'm going to be super diplomatic, of bringing in huge technology systems like EPRs into your trust, expecting that to solve 90% of your interoperability, 100% of your interoperability, which I don't think anyone would believe. And these systems come with great expense, really hard to put in, occupy a huge amount of time in your trust, and then aren't all that usable. They're quite old, the ones that we've got today. They do a great job. I think movements like Open EHR and things like that are really good. Big proponent of that. I think for me, in terms of interoperability, I think businesses and the NHS and Trust should have an expectation that get the best of breed, get the right system for the job. I was talking to another trust the other day who they're a good EPR company, Cerner. They've got a lot of Cerner in their estate. We talk with Cerner, we connect with Cerner platforms, but they didn't buy the cardiology platforms. It was going to be too expensive, or the module. And so they went elsewhere. And I think we have to expect that trusts need to be agile, they need to flex, they need to get what's right for them. And so it shouldn't be a problem that all the companies can talk with each other. We've got FHIR, but that doesn't solve all of the problem. But being able to connect these systems really simply together so that you can have best of breed, I think is really important. And you'll have a much more flexible organization. You can breathe. It's not a jumpsuit. None of us have turned up in a jumpsuit today. We didn't think, well, we'll just put one big thing on. We can actually breathe, we can flex, we've got choice, we get the right thing for our organisation. So I think it's about allowing that organisation to breathe and flex and respond actually to current events. Obviously, there's the big one, but there's constant changes amongst, the socio-demographics within an area. There's lots of responses that a trust needs to flex and move to. And I think the final point on that would be, I don't think anybody, when you go out to buy huge big IT systems that you look to solve the problem. I think the expectation is that you know how an organization works inside and out, top to bottom. And I actually don't believe any organization of any decent size truly understands how it's working left to right, top to bottom. And so with that expectation, you need to be able to take baby steps with a lot of this stuff. And so having a technology that allows you to do that, and I'm trying not to be biased because I honestly, this isn't all of my platform offering. This is a collection, this is a partner driven, this is hybrid of systems coming together to be able to build the right solution. That's what I think is the right thing to do.
James, anything you'd add on consolidation? Is it an option?
What Matt's describing sounds wonderful. I think, yeah, if Matt and other partners can deliver it, then all power to them. I think at the end of the day, I'll say it again, I come at this from a clinician's perspective. I actually don't care what's going on in the background. I just want it to work at the front end. That's it. And so whatever the best way is of doing that, ideal. It sounds like something hasn't worked, and it sounds like this might. I'm not a technologist, but this sounds good.
Brilliant. Anything from the audience so far? Anyone got a question they'd like to raise? At the back there.
Hi. I'd be interested in your thoughts on how we can exchange data between systems when actually the way that clinical data is structured within systems is so varied. I've worked on sort of trying to transfer data, and that's one problem. You've manually got to map pretty much everything because do you think there's a need for sort of standards that would make this process easier?
Pick that up, yeah. I'll do a bit. Obviously, we've got Fire standard gets us a lot further than what we had prior to that. And I'm talking about things like HL7. I don't think it's the complete answer. And you need a technology that can firstly extract the data. You need to be able to get access to it. And then I think you need to be able to, and we do this, is be able to drill down into exactly what you need and be able to do that matching. Even then, sometimes there's not exact rules for this. You've then got two options ultimately. You've got things like AI. I'm not personally obsessed with AI. I see it as a tool, an engineering tool, nothing more. But then you've also got the ability to bring in people in the loop. And so you can do that with things like applications, forms, dashboards, and allow people to be able to make those judgments. So if you're taking data from A to B, you're probably doing that with clinical administrators at the moment. You might then want to switch that. You might still use a bit of administration in the middle, but you're going to spare, 99% of their time, or you're going to, reduce the amount of time that they're involved in that. In things like cancer pathways, it's important to keep clinicians or keep administrators in the loop and not to try and automate too much or systemize too much ultimately. If that answers the question.
Yeah, to some extent. I was thinking more about your actual database structures. So if you take something like diagnosis, if you took like 5 systems, it would be structured differently in every single system with different metadata, which meant something different. It was about, I guess there's a technical way of exchanging data, but it's about the data you have to begin with, about whether you need more consistency in order then to be able to interoperate between systems.
I think looking at what is it that you're trying to build, and again looking back at the clinician or looking at the administrators or whoever you're trying to solve the problem for, and just work down that way. So again, touching on cancer pathways, there's about 5 or 6 sources with the trust we're working with that we've got to aggregate data and put it together, and it is different shapes and sizes across those systems. But I think when you know what the outcome is, that's a lot easier to do. Otherwise, it's just far too complex to willy-nilly just match any data and system. That's hopefully that gives a bit of an idea how we do it.
I think ultimately it's about the vendor community adhering to the data standards collectively. If everyone uses the same standards, then you'll be able to interrupt that data much faster. You'll still have free text added where you're going to have to do a bit of interpretation, but the majority will be standard flows of data from one system to the other. So SNOMED would work more effectively with Fire if it was implemented, for example.
Whose responsibility is this, though? Because, I don't know if that was on, whose responsibility is this was my question. Because, yeah, we're talking there about 5 different things, 5 different complete metadata, et cetera, et cetera. So who's actually going to be in charge of this? Who's driving this forwards? Who's holding who to account? How do we get there? And how far away is that? Because the benefits, I mean, ridiculous, right? If all of that data is collected in a similar fashion, we can do so much crunching of it in a wonderful amount of ways. But how far away is that? And whose responsibility is it to drive it?
So I'd like to say it's our responsibility to drive it, i.e. the vendor community, to understand the benefit and the value it will bring. But ultimately, it's got to be the buyer, the NHS, to ensure that suppliers meet those standards. And it has been done before. If you look at public health, the systems in public health all have structured data sets that are all the same. So diabetic eye screening, when it first launched in 2007, was 4 different systems. Every single system from a different vendor had exactly the same database.
I mean, I've seen there's a very large trust in the East of England who are looking at initiatives to separate their data from effectively from the vendor systems, which is quite interesting, and that they're looking at things like OpenEHR. But I see that as more as giving them flexibility to be able to put the right technology on top of that, effectively that data flow. Responsibility, I think, I've not really ever thought about that. I think we find the digital information officers, the CCIOs, I find the IT directors and associate IT directors are all clued in with this. They all seem to be conversing within around what the challenges are, what the delays are. The large trust in the East of England maintain a really efficient backlog of all the different things and the demands that are coming in from the different teams. So it seems that they know what they want. What seems to be the problem is the lack of technologies to support that outcome, to actually get that technology into play. And also there's a constraint then on the teams, the technical teams within the trust, or there's a constraint on budget, so they can't get partners in to be able to deliver this stuff. But I definitely see it's changing. It's changing, not as quickly as I'd like. I'm impatient, but it is changing. But I think ownership, it does sit with these CDIOs ultimately, or CCIOs, and I don't know.
Well, it's a tough problem to solve, isn't it? Because if those organizations are having to bid for that resource on something that is going to pay out quite a long way in the future versus something, I mean, they're all firefighting, right? And if it comes to standardizing metadata, I suppose it's difficult to make that case.
However, everyone's interest in AI is driving some of this because 80% of all the cost in AI projects are about data, getting the data from systems, cleaning up all the craftiness and the quality before you can even train your algo.
I'm going to move on before we get too bogged down in that. Gentleman in the second row had a question.
Thank you very much. I am perceiving a pitfall in this topic, and I just wondered if the panel would feel the same way as I do. And the pitfall is this. The term clinician has been used quite often in the discussion today, but clinician encompasses a heterogeneous group of people. There are primary care physicians, there are surgeons, there are anesthetists, there are paramedics. So designing a system for one group of clinicians may be great for that particular cohort of doctors, but it may be awfully poor for a different group of clinicians as well. And so therefore, I'm just wondering whether this pitfall is something that's been recognized by some of the great work that you are doing, and whether we need to look more from a helicopter perspective to try and encompass learning to really accede to the needs of all of those clinicians, not just one particular group. I do see some light at the end of the tunnel. NHS England, in some areas of the country, are pairing up primary care clinicians with secondary care clinicians to try and work together. And that joint work has really yielding some great outputs. And it's allowing each group of doctors to shine a light on that quadrant of the Johari window that the other one is not seeing. So that's the pitfall I'm seeing. A clinician is not a clinician. It's a whole group of people. And a product may only be suitable for one tiny proportion of the clinical workforce. And therefore, I'm wondering, do we need to rethink and reimagine the kind of solutions that we need to look for? Again, I'm not a technologist, and it's just, I'm a clinician myself. And this is just something that's occurred to me when I've been listening to your speeches.
Can I come to you last, because that might be the way to bring in the no code, low code.
I'm chomping at
I'll
the
start with James, as Anita's got to mention.
Yeah, so I mentioned this at the start. It's about applying appropriate resource to source that information about the system you need to design from that entire MDT, from the entire multidisciplinary team. And that's the point that I made at the start about on the startup side, the technology startup side, that's the responsibility there, which is to put appropriate resource to find that information. The other thing that you talked about that was quite interesting was that cross-pollination of information so that the same clinician can view things from different viewpoints. And I suppose, how do you then scale that? It's an interesting point, and one that I am really, really connected to, because when I was a doctor, a junior doctor, F2, I took study leave to shadow the chief exec, the finance director, and just jobbing people in the management sector, because everyone moaned about management this and management that. They see us as a number, they go home at 5. But then I went and shadowed them. It's like, well, they choose a career that goes home at 5, so you can't moan about that. And actually, they've got all these other challenges. And yes, they do see you as a number because that's their job. They have to be completely, hands off and look at you like I gained this level of empathy for that side of things that I hadn't had before. And I think you're right. I think there's so much value in clinicians, or indeed anybody across healthcare, seeing it from those different vantage points. Frankly, it's why I can do what I do now in communications, because I've seen healthcare and health tech from so many different points of view. I understand how people are thinking from different points of view because I've sat in those jobs, or I've certainly spent time with them. So I think that is such an important point that you raised. But as it pertains to redesigning systems, I just think you're right. I just think that people have to view that from all those different spheres, or that information needs to get to you, whether it's from a few people or many, many, many people. That information has to go to then the designer of the new system, because every single one of those, you're right, is a stakeholder, and their view counts, and they deserve that to count. But actually, it's important for the most efficient, perfect version of that system. And that's the important thing. There's a business reason for that. It's not just lip service. It's not just the morally right thing to do or ethically right thing to do. It's actually a very good business reason that that's the right thing to do. Because if you correct for everybody except the nurse in charge, well, game over. If it's extra work for the nurse in charge and it's less work for everyone else, it's still not going to work. So I completely agree with what you're saying.
Kevin, do we need distinct systems?
No, exactly what James has said.
Over to you, Matt. Is low code, no code part of this?
Oh, yeah. I mean, thank you. So the cancer pathway system that we built probably took us about 6 months to get the process from the clinicians. And part of that comes down to us learning how to work with clinicians to pull the process out and to get it right. The building of the system took 4 days to go live. We were asked, and a number of trusts have done this with COVID portals. They've used things like Power Apps, and some have high-coded portals. Our one, the first one we were asked to do, we were asked on a Monday. We figured out what it was on the Tuesday, built it Wednesday afternoon. It was live to 6,000 staff on the Thursday, all ready to go live. If you can build systems that quick, then there's no reason why you can't have the interface for the surgeon, interface for the unpack your anaesthetist in the list. I'm out of my depth now, but I'm usually out when all those people are around. So you can build systems that are user-centric. They're focused on the user and what information they need. That's got the power of then allowing them to get on with their job. It allows them to make the correct decisions. In cancer, it allows them not to drop the ball anywhere. That's really what we're about. That's what we think is the future ultimately. It does need things like open EHR underneath still. You need these types of initiatives as well. So we're not about build everything on our platform. But I think when you get to that outer layer within your trust and within your businesses, you need to be able to build interfaces and think about the person, think about the process. So yeah, our deal is about speed. So you can build these things quickly, you can then respond, and you can fail as well really quickly. I sat in a room with 30 CCIOs, which was an experience, and they were all fantastic, and it was quite intimidating. But you could almost see there the polite arguments. It was for one of the big EPR vendors actually, and they were talking about they wanted a button in the corner of the screen, and someone was arguing, no, I don't want the button there. And it just struck me that might have been the problem that, going back into 2005 and things like the National Programme for IT and things, is if you've got way too many stakeholders all trying to chip in, there's no common agreement. So forget all of that and then build a platform actually that serves these individuals or serves these localized teams. It's probably more of a trust or a, specific thing, and build those interfaces for them, get them all onto a common platform, and then slowly start to merge people over time. It might be 10 years, 15 years, but you can fix the problem whilst keeping the lights on, rather than trying to build a system that satisfies everyone, which we know doesn't work.
Is part of the analogy, Matt, therefore, a bit like hardware in that your paramedic needs a ruggedized tablet because good chances it's going to get put on the road and SUV will go over it. But ultimately, it's the software on it could be very similar to what somebody bedside in a ward will be using, but they only need an iPhone or a much lighter form of device. Are we moving in that sort of analogy with software now? Is actually we can bespoke the software to the user and the scenario, but wrap it according to user?
Yeah, exactly that. I believe that when I was on the receiving end, when I was an employee for big telecoms firms, and it was a nightmare using things like SAP, which is, again, not a bad system. It's a bit old, but there's good stuff about it. And if anyone from SAP is in the audience, sorry, but it was really quite clunky to use. And it was what I call visible technology, slap bang in your face, shouting at you, saying, understand me, learn me, you're going to have to use me, you're going to have to figure it out. When you sit in your car, you don't have the steering wheel screaming out of you. You know how to use the gear stick, you know how to press the accelerator. It becomes invisible, it becomes intuitive as part of what you're doing. And I think that's the whole world of user-centric design and focusing on how people want to work and getting that usability right is really important. And I think all companies are moving in that direction. The big EPR players are going to move in that direction. Of course they are. There are other dynamics at play there as to whether they want to play with all of the other partners that are around in that ecosystem. Time will tell. We're dead keen on working with all the big EPR players, for instance, and helping them tackle all those issues around the edges. But I'll probably go off point slightly, so I'll stop there.
Building on that question, how do we prevent, though, the risk of excessive customization, which can lead to, and we've seen it not just in healthcare, but in every form of enterprise, increased maintenance and technology costs? Kevin, is there anything you could share with us there?
Yeah, I think the strive is to eliminate customization and promote configuration, because configuration is something that makes it personal to the user and is something that's scalable, so you don't have the maintenance issues in the future. Sounds very simple when you say it quickly, doesn't it? But yeah, configuration over customization every time if we can.
James, is that something you see?
I've just never heard it put so eloquently as that before. I did almost a whole panel on this yesterday. That never came up. My question would be to you then, what's the difference between configuration and customization in your view? Is that just a slightly different front end, or you tell me?
No, so think about using Microsoft Word. If you want to achieve something that's slightly different, you configure it. You don't customize it. You don't write a new piece of code that then needs to go into your product roadmap, and you have to think about how you release and test it. It's just configuration.
By that you mean you sort of go into the template, so I'm writing a CV or something? Yeah.
Understood, thank you.
Nice. Matt, anything you'd add on that?
No, fully agree with that. It comes back into the no code and the low code area ultimately. So yeah, agree, and well put.
And when you're talking to healthcare organisations, do you find that they're at a point where they've got so many point solutions, and what they're actually trying to deal with those point solutions at the moment is they're adopting other point solutions, arguably things like RPA has been accused of being a point solution, to get over that hurdle rather than stripping back layers and as we've started this debate, looking at the user and how they need to do their job.
Yeah, one's a really quick exercise to solve a problem now and firefight to get to tomorrow without any patients coming to harm, and the other one is a whole exercise of redesigning, reevaluating absolutely everything. So understandably, healthcare is put together by a lot of workarounds on the individual basis, on the system basis. I've seen this as a clinician, I've seen it on the managerial side, I've seen it from the technology side, that it is just a hodgepodge of firefighting elements that somehow come together on the goodwill of the staff. And I think any time that responsibility can move over to a company that can, you've heard 6 months to listen, 6 months just listening to clinicians as to how they should want something built, and then 4 days to build it. The tech's already here. The technology exists. The IP is clearly how do you get the right answers in 6 months to build something properly. And it's interesting that responsibility has gone over to the company, and you know, in a way, rightly so, because they're the ones that are going to listen, build, run it next door potentially, or you know, run it in parallel and show them that things could be better. And yeah, it's great because everybody in healthcare is just trying to get to the end of the day.
And there's an interesting parallel with that, which is in the wider economy, is the startups, isn't it, who just pick technologies off the cloud because they've listened to a customer base or they've seen a gap and they've gone for it.
Yeah, I think that's what trusts need to get themselves into, but all companies need to do this for the next 10 years. Trusts don't have the competitive angle, whereas, you know, the limited companies do. But I still think that the trust need to get themselves into a position where they can use the best of breed technology and they can use the right technology for the job. Also, if they can bring it in as quick as they can get it out, then they can breathe a lot better. They can flex and adapt and they can get things exactly right. They can also get the commercials and that competitive advantage just right too. So my view is a partner ecosystem that interoperates and cooperates rather than a big single purchase ultimately for their IT estate.
Yeah. Anything to add, Kevin? No? Any further questions from the audience? We're quickly running out of time. I'll press on. No, I've got lots. I mentioned startups there. There is a wealth of new technology firms coming into healthcare and a wealth of interest and forums for this technology. But are there still barriers that prevent those innovations coming on board and therefore by coming on board being well connected? So that, you know, as a relatively young player, how have you found it getting into the trust and then working with the other technology providers we'll start?
Yeah, we started as an RPA company years ago, and we focused mostly on RPA. We always had a vision that, and for those that have used RPA or who haven't, RPA is an automation technology for automating existing platforms and automating them via sort of a GUI view, like a human would use a system. It's a bit Heath Robinson. They're good for workarounds and getting, you know, a quick bang for buck, but they don't always scale that well, those technologies ultimately. We've got that at the core of our product. We use it for when we need to integrate into, let's say, PR platforms or PaaS systems or whatever it happens to be. I think in terms of the governance then, again, back on the NHS and thinking about organisations like NHSX, what they're trying to do is drive innovation ultimately into the NHS. And to that, they're doing it well. I think where they need to leave room is for the technology market to give the answers. I think all too common, and this isn't just in healthcare, I've seen this at a UK border agency, I've seen this in a number of other government organisations, is government likes to call out what is needed. The problem there is that the government, if that team, those people have just picked up a technology of the day and then peddle it and spend 5 years saying we're going to throw millions of pounds to vendors who work on this technology, you're actually killing innovation. What they need to do is need to be a little bit more flexible around how they fund capabilities. So they almost need to be able to fund the trust. The trust know the answers. They know what technology is needed. There's companies like mine who are providing offerings and platforms to say, here's an answer. And I think where the governance layers within government and also at the top of the NHS, they need to be able to fund these different technologies. I have, at least once a day, I have to say to somebody, we're not an RPA company. And then I explain what we do and we say, so I'm going to put you in touch with the RPA, the head of RPA. And it misses the point of the technology that we're doing, but it's because everything is gone into these little compartments of, oh, you do this technology and this is a badge for you. The frustration, as you can probably hear, is it does constrain the types of opportunities that are out there. And just picking on the gentleman that asked the question earlier, what he's talking about can't be tackled with some of the technologies that are kind of the big headline technologies. You need these no-code and low-code fabric platforms that can do apps and can do integration, automation, TalkFire. You actually need a much broader capability in order to answer those questions, but no one's really talking about it. And I guess that's why I'm here with my opinions today.
Kevin, you've helped a number of organisations. I mean, are there still challenges there?
There are challenges. I mean, innovation is hard, right? You've got to spend a lot of time thinking about what's needed today, what's potentially needed tomorrow. You've got to convince somebody that you can see the problem better than they can, articulate that value. And then as a startup, you don't really have a route to actually get into the system because everything's procurement based. Often you're too small to actually meet the financial thresholds and even get onto the framework to actually start having those conversations. And then when you can, you face the challenge of everyone inside the system is super busy, but they want to test it, but they don't have time to test it. They don't have time to run a pilot, really. And then when they want to adopt it, it's another piece of technology that isn't integrated with their existing systems. So that's why interoperability is so important.
Anything you'd add to that, James?
I mean, I could talk about the barriers to health tech startups entering the market all day, literally all day. I could talk about this, but I mean, EMIS partner program, that's 10 grand, getting regulated in any way, shape or form, 100 grand. Like the barriers are just there, everything that's been talked about. I think just interesting on what Matt was saying, I think there's an interesting role. I think it was talked about in the Topple review, actually, somebody that knows and understands the technology landscape deeply, that sits as the gatekeeper for a critical appraisal of all the startups that knock on the door, and indeed that can go out and have a look and figure it out. A born and bred expert that understood the needs of the organization as well as a fantastic understanding of the technology landscape. That, as somebody who can critically appraise everyone coming through, I believe would be an excellent role for someone like me to do across lots of hospitals, or Kevin. But on a serious note, I do think it's a really interesting concept that I think was talked about, at least in part, in the Topple review.
Any final questions from the floor? Gentlemen, thank you for a fantastic debate. I mean, I suppose in summary, in the world I live in, it's fascinating is actually interoperability remains a big issue in healthcare, but so does it in business. And I'm seeing huge changes in the business world. Organizations now doing everything via Teams, and if tools don't interact with Teams or Slack, then those tools get forgotten and lost, and that's become a huge challenge in the commercial world. So the healthcare world shouldn't see its interoperability as as it's just their problem. It's not. It's one that the business world is struggling with too, because our worlds and our economies are changing. It's been a fantastic debate. Thank you, Matt Rule, Adam. I'm sorry, I got the wrong name. Kevin and James for your insights. It's been really interesting, and I hope you all enjoyed it. Just one final thing is Toka, we're giving away an iPad as part of a prize draw. So if Dawn Watson is amongst you, head down to the Toka stand. Thank you.
Thank you so much, guys. Thank you. Thank you, James. Fantastic. All right. Thank you so much.
Thank you.
Great moderation. Right. Okay. Mic on. Good. So what we're going to do now is have a demo from a company. But before that, we've been around for 7 years in Giant when we first decided to bring communities together. One day, I hope not to show the words interoperability on a slide or a debate. Hopefully at some stage we'll figure it out. So Kevin, no pressure, and James, if you can sort it out in the next 12 months, we'll be so grateful. And then we won't invite you ever again. Is that right? So it's an ongoing discussion, of course. Right, so it's been a great day, great 2 days, really enjoyed it. We're almost at the end now, and we've got a live demo coming on. So question for the audience. Do you know what the medical negligence bill is for NHS? The medical negligence bill per year. Have a guess, go on. Any ideas? It's over £80 billion a year. Can you imagine? That's how much we pay as taxpayers for negligence across the UK. I'm not sure what it's like in India. I have no idea, but it's significant. What's the NHS total budget? Do we know? Anybody? Huh? Over 100 billion, about 120, 130 billion. So it's almost the same price we pay for NHS. And the problem that occurs most commonly for negligence is lack of communication. 2/3 of all the complaints around where you didn't communicate with the patient. We didn't do the right operation. There's problems outside. We didn't have the duty of candor. So could we improve communications from a bleep that's 5-decade technology old? Can we communicate better in terms of having, these kind of when you're on call, handing over, having communications in the HR, all that kind of stuff? It's been time. Memorial have been doing the same thing for over and over for many years. So communication is a real interesting phenomenon now in healthcare. And now we've got a company called Alertive, previously called Common Time, is that right? Who are now thinking about solving some of the issues. NHS, NHS Digital, NHS England is as a priority, but how do we communicate better? And during the pandemic, it was so important to be able to communicate effectively. So it's so relevant. So Chris and Ilya, take over. I hope it's all working for the tech.
Is there one up there?
Yeah.
Thank you very much. Okay, thank you everyone for joining us here for the Alertive showcase. So I'm Chris. I'm one of the sales guys at Alertive.
So I'm also one of the sales guys at Alertive, and thank you for coming up. Yeah.
So we've got a little video here just to kind of introduce ourselves to start with. It does have sound. Yeah. I'm getting a bear with sign. Okay.
Hospitals are dynamic, fast-paced environments. To stay on top of patient care, quick and effective communication is vital. Pages and bleeps are great for getting a colleague's attention, but poorly suited to sharing detailed information and often require time-consuming manual follow-ups. Sometimes, this leads to staff using consumer messaging apps, which are neither secure nor GDPR compliant, and critical messages often get lost in personal chatter. Introducing Alertive, your gateway to better communications and clinical information. As hospitals become better connected, the opportunity to use mobile devices to support NHS professionals at the point of care is becoming significant. Alertive helps prioritize communications and activities, making it easier for healthcare and emergency response workers, saving them time, stress, and helping to reduce risk. With Alertive, you can send alerts that reflect the level of urgency, hold conversations where you can share text, images, or audio files, and stay up to date with changes in patient status or recently released blood results, all in an application that is secure, GDPR compliant, and auditable. Alertive can help create a hospital environment that's better coordinated and enables professionals to spend more time delivering care.
Perfect. So hopefully that's given you a little bit of an insight into what we're all about. It's all about ensuring that the clinical communication of a hospital is kept in one place, that is IG compliant and secure. So we do this via kind of several different ways. So the first is our critical alerting, which has demonstrated the ability to replace the aging bleep technology. There's one-way pages in a two-way, much quicker, much more secure way.
Yeah, and the others are the clinical messaging and event monitoring. Clinical messaging is the alternative to WhatsApp, if you like, in a safe, secure, GDPR compliant way. It's all ISO accredited, and the data that can be discussed on there can be patient confidential information. It's stored all in the app, and people can have one-to-one communication. They can have group conversations. They can have requests, and if you want a second opinion, you can do all of that, send images, and so on. The event monitoring revolves around the integration with things like blood updates or EPR integrations, and we also offer some of that as well.
The clinical tasks and priorities is all about managing processes such as hospital at night and other task management functions like order comms, things like that. It helps hospitals to navigate spikes in activity, and again is fully auditable.
So these are just some of the trusts that we are working with, and we've been working with for the last few years. We have just rolled out at Princess Alexandra Hospital and Norwich just recently. This comes part of the clinical communication framework by the NHSX that we were successful on last year. Working through that, we were the most successful company to present this critical alerting and just communication in general. And we're very excited for the next year when we're going to be adding to some of these trusts as well. And there's some big names coming up.
Perfect. So we've got some testimonials from some of our most recent rollouts across the NHS. I won't sort of spend too much time on these, but we've got Helen Pardo at Princess Alexandra. And if we go on to the next slide, you can see Norfolk and Norwich, who are a little bit more mature. So we've got lots of really, really positive feedback from them. Lots of C-level engagement as well, which is really, really good for driving that use out to across the wider hospital.
And in general, when we look at the solution, we always like to think of it, what are we trying to solve? What problems are we solving as a company? And some of these numbers and statistics have come up from our own studies and discussions within these trusts. And we've seen that the challenges with bleeps, the traditional physical pager bleep that a doctor would use or somebody in the hospital would use, the actual efficiency of that, we've seen that a lot of 17% of the junior doctor's time is wasted on unproductive tasks. So that's looking for the number to call, looking for a phone, who to reach, When they reach them, is that person there? If they're not there, they send a message. They're waiting for a response. It's a one-way communication, very archaic, very slow to respond. And the costing in one trust that we were studying was about £4.7 million that this could potentially save. The other problem statement that we often face and that we've seen are workarounds people turn to. So people using WhatsApp or other non-compliant messaging solutions just because they're used to it from the personal life, and then sending the wrong photo to the wrong person in the wrong chat. That's a breach, that's an offense. They could lose their medical license, the trust can get in trouble. And they still do because they're familiar with that. We're trying to provide this application where the doctors and the nurses, medical staff don't need to be afraid of what they're discussing. They can openly speak about the patient and have reassurance that this is all safe, compliant, and they have their back saved. The other thing is the disconnect with clinical systems. So we've noticed that trusts often, we say 12% of critical alerts fail to be received. Everybody says pages are guaranteeing even when there's no Wi-Fi, there's no signal. But what we found is that there's no way to test it. And when we sent a bleep to somebody, 12% of the time, even standing next to them, they didn't receive that. They just failed to transmit via the radio waves. And there's no way of testing that. So if you send out a bleep to somebody and it doesn't get through, you don't know it didn't go through. They don't know that they were supposed to receive something and something happens. And in a hospital scene, that's usually a bad repercussion. So our solution, you have a way of seeing who sent it, when they sent it, did the person receive it, when they received it, did they read it, did they respond, and so on. You have this accountability, you have this understanding of where that message is. And so, yeah, that's some of the things, the problem statements.
Yeah, I think it's interesting as well, just before we come on to the demo, some of the things we've learned with some of the sites that we've recently gone live with, it's important to get buy-in from everyone. And from a clinician's perspective, they tend to be quite resistant to change. Particularly senior clinicians, they tend to have everyone's phone number. They don't mind just picking up the phone to them. They'll go and they know everyone who they are. So the way we've looked to try and engage them is through some of the real transformational pieces, which hopefully we'll show you when we get onto in the demo. But really get them excited about some of the EPR integrations, some of the bot frameworks, really trying to make life easier for them. So from a clinician's perspective, that's how we've tried to engage them.
And of course, when you're looking at a hospital, it's not just the doctors that are involved in this communication. There's the nurses, the other staff, and some of the studies that we did with the nursing staff, we found that they have a different perspective on this. They tend to not like new systems. They tend to not have a reliance that everybody has their phone number. They don't want that. They want to have this separation from work and personal life. And the adoption has been typically slow when you're adopting a new system for the nursing staff. And we've worked with Princess Alexandra Hospital and a number of other ones where we specifically sat down with the nursing teams, the chief nursing information officer and so on, explained to them the benefits, the fact that they can separate the work-life balance, they can sign out at the end of the day, they don't need to be messaging. And one of the examples that we heard was that a lot of the nursing staff, at the end of the day, they would uninstall WhatsApp just so that people would stop messaging them and install it again on the next day when they're back at work. I mean, that's crazy. That's crazy to think about it. So with our app, they can just sign out when they're done working. They won't be bothered. They won't be alerted. And when they come back to their work, they sign back in using their NHS email address. It's all professional. They can have this work-life balance, even in the crazy times of the pandemic where they're overworked, they're stressed, and they need the separation sometimes.
Absolutely. I think that some of the really good feedback that we've got is actually that almost the most simple of functionalities has been kind of some people's favorite feature. So that's really good to see. So if we get onto the demo, my phone isn't struggling to connect to the laptop. Maybe before we get a bit closer.
Speaking with the audience now.
This is the interactive section.
So what we're going to do next is just screen share his phone, and I'm going to message him a couple of messages. He's going to message out a few things, and we'll work from there, show you what it looks like firsthand, what the users will be seeing, and so on. So typically, this would be like on a mobile device. This example could work on an iPad in a trust. It can work on an Android, iPhone. This is an iPhone, for example.
Yeah, absolutely. So hopefully what you saw there as I was walking across is the two-factor authentication that we support through the Face ID in this case, but it could be fingerprint biometrics, whatever it might be, that allows us to support BYOD models. Once we do that anyway, this takes us into our kind of home screen. Kind of beyond there in terms of logging in, if we sign out, I'll show you how that works. So you're signed into a particular environment. So each trust or each organization that purchases alerted will have their own environment that this will sit inside of. If I click on the sign in button, I can select that environment. And what that will take me to then is a login screen. Now, I have like a test account, so I'll just sign in with my password. But for the NHS, you would have NHS Mail supported. You would link with your Active Directory and just sign in that way. So if I just enter my password here.
So you don't need a phone number. You can just sign in with your work email address, the one that you're using in your trust every day, and it authenticates through the NHS Mail. All of that is done.
Okay, so this is a live version of the app. So obviously I'm in a test system, but it's a live version. The alerts that we're going to send backwards and forwards, they're live as well. There's no kind of smoke and mirrors. There's no magic. This is what it is. So as we mentioned, this is on iOS. So the apps are natively built. So they would look and feel very, very similar to the other apps on your phone. It should feel very familiar.
So can I just check that he has his silent mode on and do not disturb mode, just for the presentation. We'll show you one of the interesting features of the app. So right now what I've done on my phone is I'm about to create an urgent task, an urgent alert. So this is mimicking a pager or a bleep in the system. So I've done it and I want urgent help, and I'm going to send it out. What's going to happen in a few seconds is that even though his phone is on, this do not disturb mode, he's still got the message, and it's come through. I can send a message to him, like, hi, that's come through. And for example, in this case, if he locks his screen, if we do that again, and his phone was in his pocket, he's been away, he couldn't get it to work, and I'm writing another message, writing another description, and I'm sending it through again to Chris. And even though it was locked, it's in his pocket or wherever in his bag, I've sent that through. And on my phone, it says it's being sent, it's being received. And you hear that's come through. He has a critical alert. And if he opens up his phone now, and he's got the description, if he goes back to see the new message, he'll see it there, urgent, I've just sent that. He's got 5 minutes to respond. On the bottom there, he has an option to either attend, or if he's unable to attend, I can send it to the next person who's in charge. In this case, he is or isn't available. He can write a message as to why he's not available. In a typical pager system, there's no way that he could respond. So I have no way of understanding, did he see this, did he get it? So he said he's busy, so he can't come in. And I know that. I can respond, I can find the next person, and that's it. So this is a two-way messaging in a bleep, essentially. Yeah, Chris.
And I think that side of it is really important. It's not that fire and forget. You're not, you're not losing that context of the message. There's no way of triaging it. You can see the information about the alert and respond to it accordingly. So from here, if I just take you back a couple of steps, I can take you back to all the conversations that I'm having. So the idea of this is that this is your hub for all your communications. And you can filter that by chats, for example. I can filter it by the alerts that Akilia just sent, or any tasks that I've got outstanding as well. Now, they're all different types of conversation that we can be having kind of within the app, and you can see the different levels of urgency of them as well. Okay, so if we create an alert.
Yeah. What I'll do now is I'll put my phone on airplane mode, and he's going to send a message to a couple of people.
Absolutely, I'll do that. So from here as well, you can see that I can either send the alert as myself or as a role that I've picked up. Now the roles piece is something of a USP for us, because what it allows you to do is pick up conversations or alerts, regardless of where you are, as long as you're in that role. And it means that if you're, like I said, more senior clinicians, they tend to know everyone, they know who they need to get hold of. But if you don't know who you need to get hold of, but you know you need to get hold of a particular role, for example, you can just search by a role and raise an alert to them directly, rather than having to know exactly who it is, because it's not linked to your mobile number, anything like that. What I'll do, I'll create this alert as myself. Now I've got a choice here of the type of alert that I want to create. So I can do an urgent priority alert, which is the type of alert that Ilya sent to me a second ago. Now that will break through lock screens, do not disturb, silent mode. It will break through all of those things. We've got a partnership with Apple, which means on iOS we use their critical alerting functionality. It's normally reserved for kind of earthquakes and things like that, but we can use it here. And there's similar functionalities on Android as well. We've got a pager alert, the second one down. Now, this is similar, but it won't break through lock screens in the same way. That's how we've got it configured. We've got various different types of conversations as well, and we'll come on to those in time. So if I send an urgent priority alert, I've got the choice of who I want to send it to here. So I can search, and again, we can search by users, roles, or even groups of people if we wanted to. In this case, I'll search for Ilya. I'll add Carla in and Phoebe.
And you notice you don't need the phone numbers. There's no way of identifying their personal phone numbers, which also helps with the separation from work and business, essentially.
So I can set a title for my alert. I can add some additional information, and I can set numerous different response options. So whether attend enable, yes, no, or a simple acknowledgement. In this case, I might just want them to acknowledge. I can also add an image if I wanted to, or any audio. I can record some audio and send that through at the same time. Click on create, and there should be a stereo effect going on.
So we've got some messages there, but if you noticed, you didn't hear mine. Mine didn't go off because I was in airplane mode. So imagine I'm in a lift somewhere and I don't have signal, but I still need to get the message. So you see it's still delivering, but it didn't deliver. So now if I take my phone off of airplane mode and get a signal, it's saying it's trying to deliver now. And when you look at it, it'll say, okay, it's trying, and it's taking a while. But then as soon as I have signal, it'll come through. And if I look at my phone and look at the messages that I received, there's still nothing through. And it will come through and say the same thing that Phoebe or Carla got. And if you go onto messages, you see that I've now received it. And it says I received it a minute later than the others. If you look at messages there, you'll see that the others have responded. Okay, so Phoebe's on her way. I've just received it, so then I can also say I'm on my way, and so on. So even if I'm in the lift or in a bad reception area, I can still get it afterwards when I do come back into signal.
Crucially, though, for me as the sender, I can see for the first time, I can see where people are at with it. I can see if they've received it, whether they've read it, and what their intentions are behind that alert. Rather than having to wait for a call back, which could be, 20 minutes or so. You saw when I replied to it, you can reply to it with one click on those response options. So really, really easy. And for the first time, that's available. For the people that have received the alerts, if they needed some clarification from me, for example, they could quickly, ask for some clarification, and I've got the option to respond to them in a message really, really quickly, really, really simply, and crucially, for the patients, their care begins sooner.
So in general, just to round up what alerting is, it's just not a one-way communication system. It is a two-way communication. You can have all of this information. It's all auditable as well, and we can really understand who's receiving it. If they're not able to attend, then the next person in charge will be able to attend and come up to the situation, help with the acknowledgement and so on. And you're not going to be wasting valuable time in a hospital setting. This is very, very important. Time is of the essence. and you have a visual representation of everything that's happening in this communication. So yeah.
Okay, so moving on to one of our next pillars, we were talking about the clinical messaging. So if I bring these up again, and the different types of messaging that we have. The first type of conversation we can have here is a patient context conversation. We can have named conversations, direct conversations, all sorts of different types of conversations. Some of the key bits with these is that where users can be added or removed, they can go back and view what happened in the conversation previously. In healthcare, context is so important, and that isn't lost here. Okay. So the type of conversation I'm going to create is a patient context conversation. So this is where generally we've integrated with a trusted EPR system, something like that, and we can have a conversation directly about a patient. So if I select that, I can add people to this conversation. So again, I'm going to add Ilya, and I'm also going to add this clinical assistant. Now this is a bot. It's not the bot. It's you know, a sort of bot we can use to show off some of the cool features that we've got on there for you. So click on next, and because it's a patient context conversation, what it'll ask me to do is set the patient that it is. And the first thing that does is open the camera for me, so I can scan a patient's barcode.
So if I've got a barcode on my wrist, if I'm a patient or it's lying down, you can just scan that through. It's just on my phone. It populates all the information.
Yeah. So you can say, oh, okay, Mr. Smith, can you just confirm your postcode for me and date of birth, whatever it might be. Okay, we're talking about Mr. Smith. Right, we'll confirm that in there. We'll say we're concerned about Mr. Smith.
And you've got that double check that you're treating the right patient with the right things at the right time.
Okay, so that starts a conversation now about Mr. Smith. So as anyone else involved in that conversation, they can click on the patient's record, they can bring up, they can see where the patient is, all the relevant information.
So what I've done is messaged him, can I get the bloods, please?
Okay, so if we bring the bot into the conversation and we can say, right, we want to see the bloods. We've got the / bloods. Now, we wouldn't expect clinicians to remember all these sorts of commands. We would kind of surface these as UI features using the plus button there. But for ease of showing you on something like this, it's much easier to do the / commands. But you can see it's pulled straight through the blood results. But this, this could be anything. This could be allergies. It could be anything like that. So what we might see here is, as Ilya is saying, okay, these bloods look old. Can you let me know when we get an update? So I might add in Carla to this conversation. To say, okay, Carla, can you get a new blood results for me? Can you do a blood test for me?
And then, as a doctor, I don't want to be sitting there waiting for these results, checking my phone every 5 minutes. I want this to be done and sent to me when it's ready. So
what I can then do using this Bloods Watch command is subscribe to those patients' blood results. So what the bot will do is check every minute to see if those results have been updated, and will then notify me when they are. Again, this could be anything. The blood results is just an example, but it really nicely shows you some of the event monitoring capabilities that are in the system.
So it'd be good if we can transcribe this conversation into my EPR, so then I don't have to sit down at the end of the day and write everything up again. Is it possible to do that? Yes, it is. So we've got one button, click of a button, we can transcribe all that discussion into the EPR, whether it's a photo that's been sent, whether it's something that I'm asking somebody for a second opinion, that's all kept on the record of that patient in real time.
We can also do that just from here as well, just that button there. So multiple different ways of doing it. I think for OneTrust, we also just automated that process where every patient context conversation where it was kind of clinically pertinent, we just transcribe that to their patient record. Okay, that brings us nicely onto the tasks element of the system then. So tasks really, it's about those more formal requests for updates. I suppose everything we've covered so far has been quite reactive. It's going to be quite disruptive for the people receiving those alerts. but tasks is a bit more structured than that. So again, if I go into here, I've got various different types of tasks. So we've created a hospital at night task, which automatically sends the task to a central coordinator who can then distribute the task accordingly. We've got a direct task where I could just ask Ilya to do something for me. Mm-hmm. Or we've got a patient context task, which again, similar to a patient context conversation, is like it kind of revolves around the patient. Okay, so if we look to set up one of those, again, you can see here as part of the process, it automatically includes the patient flow team. So there's someone else who's always kind of responsible for these. Again, I'll add Ilya onto here. Again, I can search for the...
So I've got another patient that I'm looking after. So if we do that, we scan that in.
Okay, so this is Mary Smith. So again, Mrs. Smith, confirm your date of birth and postcode for me. Title. So let's take a use case that we had recently where the nursing staff wanted to contact the porter team and give them a task to move a patient from one location to another. Really, really simple use case. But what they were finding was, you know, the nurses would bleep the kind of the central porter bleep, and then they wouldn't hear back, and someone would just turn up kind of half an hour, 45 minutes later. Yeah. But, you know, in that time, the patient's concerned that nothing's happening, you know, they're asking for updates, the nurses don't have them. So they wanted a way of kind of simplifying that whole process.
So in this way, you can, again, attach an image, audio file, just say, look, we need this patient moved from ward A to ward B. They need to get an X-ray in between. Can we do this? And as a doctor, I would be able to basically go into this and see where that patient is since the last time I saw them, since an hour has elapsed. Are they still in the same place, or have they been moved? And this has an action, and I can keep an eye on that.
Absolutely. So if I create this alert now, again, this is set up to be quite a disruptive task. So you can hear Ilya's, you caught it very early.
Yeah, I just clicked on it, yeah.
But you can hear Ilya's phone going off with the bleep. I can see the responses from here. So I can see he's received it. I can see he's read it.
So I can either accept it or decline it. So I'll accept it. And he can see that I accepted it straight on 4 o'clock.
And being one of the differentiating factors about tasks is rather than just having like you know a singular accept, reject, acknowledge, yes, no, there's then a series of decisions and feedback that Ilya can give me in terms of how he's getting on with that task.
Yeah, and if you click on details there, Chris, you'll be able to see the information that was sent, what's happening. So this is what I see as well on my screen, and it says I have 16 minutes to accept. So again, this we can do this with the trust. We can set this up. I've acknowledged that I've received this, and I said I've done this task.
So as Ilya is going through this process, you know, if I'm the nurse that's with the patient, I can reassure the patient that someone's on their way. You know, they've received it, they've responded. You know, they're in progress. They're going to be here in 5 minutes, 10 minutes. You know, however long. You know, we can have the chat about it. And nicely there, Ilya has told me that that's all done.
So I think that's a good place to finish the demo and just summarize what we've discussed. If we just get rid of that. The final slide is just summarizing the information that we said, starting from critical alerting. I know, Chris, if you want to say a few things to end.
Yeah, absolutely. I think one of the things we promised people was that we would draw the champagne raffle now, so that there was a quick survey on our stand that people could fill out, and with the chance to win a bottle of champagne. I don't know if we can send an alert with the winner on there. You felt about this?
I got an alert. Let's see, what's this? No, it's on mine. Just to keep it safe. So we've got, okay, so the winner is Hilgard at Royal Brompton Hospital. So we'll make sure to get it to you. I know you're not in the audience at the moment, but we'll make sure to get it to you very shortly. Thank you.
I mean, if there's any questions for anyone, we welcome any questions. to write these down.
Allowing people to allocate to different roles, that seems like a good efficiency measure. But with the other tasks that you brought in there are sometimes elements where kind of being uncontactable can, I know it's not always an advantage, but sometimes there are certain advantages in terms of like how you manage your day and go about your day-to-day tasks. Are you getting any feedback from sort of action that people are getting sort of notification fatigue? And then the third thing was any plans to bring sort of primary care into this realm to try to get advice and guidance from our sort of esteemed colleagues.
Yeah, absolutely. Okay. So first question was about coverage. I'll just try and remember those together. But yes, so that is, it's obviously a concern everywhere. You know, people want to know, are we still going to get the alerts? You know, people, like Ilya touched on earlier, they assume that pages are some kind of bastion of reliability, but in reality, it's just because it's not auditable. They don't know. We have done coverage tests on all the sites that we've gone live on. And we've had some really, really good results with 100% of our alerts arriving within 2 seconds. So we do that. We do those coverage tests. We work with hospitals. You know, there are certain areas where the Wi-Fi is not so good, so we can also work with them to improve infrastructure and things like that. Second question was notification fatigue, alerting fatigue. Yeah, I think there's a couple of sides to that. So there's the sign out button. You know, that's really key. So when you're not in the trust, being able to sign out and not being contactable. Again, I think like Ilya touched on, having people uninstall WhatsApp isn't a good thing to be doing. So to be able to do that, but also the tasks themselves, they can be configured in different ways. So, we showed you one that was going directly to Ilya, but the hospital at night tasks that we've configured, and again, it will be different trust by trust how these are done. But rather than going to an individual, they go to a coordinator who can see the tasks that everyone has via the desktop version of the application, and they can then distribute out accordingly. And there's the ability to reject tasks as well, so you can decline to have them. Obviously, Ilya very kindly accepted mine, but you could decline, and then, but crucially, away from the one-way side of things, if I've sent a task to Ilya and he's declined it, well, I can do something about that now, rather than just a page that isn't answered. So hopefully that answers that question. The third one, you'll have to remind me. Primary care, yes, absolutely, yeah.
Sure, yeah. So that is one of the ventures that we're looking at as well. We've just recently signed our first ICS up. Previously, we've been looking at secondary care, but now, obviously, with the ICS that we're looking at, there is this aspect of primary care. We've got GPs that could potentially have a shortcut into the system to get the advice and guidance that they need without having to sit on the phone and wait for 20 minutes while they're ringing the hospital to get through to the right person. They could just contact the right role. So they can say, this person is, the cardiology person responsible at this trust for this GP practice. That person doesn't have to be an individual, like Chris was saying. It could be somebody in a baton role who picks it up Monday, then gives it away on Tuesday to the next person, and so on and so on. So the GP doesn't need to know the name of the person who's on call for that particular area or location. They can just be contacted no matter who it is. And the good thing about Alert, again, with that, is that when you pick up the baton, you'll be able to see the history before. So you'll be able to scroll back and see, okay, so yesterday my colleague was dealing with this GP practice, and this was the conclusion. Okay, now I know, I'll continue from what I picked up. So I guess to answer that, that will be the primary side of things. We are looking and we're working with emergency response units, so ambulance services. There's one group of critical care transfer team that we're working with. We're just setting up this month to basically transport patients from one hospital to another hospital when a speciality is not present. So if a patient has an accident and has brain damage, hospital A is not able to have a specialist to treat them then and there. So they use this transfer service in an ambulance to bring them to the hospital B, who then have those specialists, and all of that communication is done via alertive when the patient is brought in, when the patient is discharged, moved to the next place, brought into the next place, and so on and so on. So that's another example of, I guess, work that we're doing that's outside the secondary care team. And there are others, other examples we can give you as well. I hope that answers the question. Very good questions. Anything else? Any other questions? No?
A question for me. So there's lots of platforms out there. And obviously NHSX has made it more available now with funding, etc. So if everyone's using different communication tools, what happens in the future? How do you connect that? Because we had a whole conversation on interoperability earlier. So what happens in the future in terms of different comms? So I think what we liked is one system that everyone communicate with across the UK, across primary care, ideally. So what do you think
I think that's a very good question as well, because at the end of the day, I guess that touches what other people are doing this. And we find that a lot of people are either doing clinical messaging, or they're doing critical alerting to an extent. They're doing the event monitoring, they're doing the tasks, but nobody's doing it all in one. And what you tend to see with a lot of trusts is that you get silos of people using one app, silos of people using another app for one thing or another. And the clinicians are overwhelmed with having to use 5, 6 different apps to do all of the things that they need to do. And what we've done is combined all of the most essential ones that we've worked with trusts to develop this product. And we've combined the most important ones all in one package, easy to use and easily accessible, without having to use and need loads of different apps to do the same thing. And I guess, I don't know, Chris, do you want to mention anything?
No, I guess that's the idea, is to have all your clinical communication in one place. That's why we're keen on doing some of these integrations and working with other systems. Yeah, it's why we do it. It's the whole program with the ICS is to be more integrated, to ensure things are easier for clinicians.
And connecting to EHR is the critical part, right? To capture the data. Epic, Cerner, even Teams, right? Because that's what we're using now, right? So what's that look like for you guys?
So we have Teams integration already. That's working wonderfully. And we also have various EPR integrations available. We're working with one trust. Is it in the Midlands or Norwich? I can't remember, but one of the trusts, Imperial as well, with Cerner. So we have Cerner integration, and we do have an ability to develop a lot of this in-house. So we have
but companies open up their APIs.
Yes, exactly. So they open up their APIs. We have access to that. We can read and write the information that's necessary. We agree with the trust and the data protection people what information we need, how we're going to do that, and that's what we do. We read the information, we send it back, transcribe it, and so on.
I think for us, it's all about working with the trust, with the organisations for what do they want it to look like, how do they want it to work, and what's technically possible, and let's work together on that.
And every trust does things in a different way, and what we try to do is we tailor it around that trust. We have this generic template that we've developed, which is really good, but we make it better and more specific to that particular trust when we work with them, to their EPR, to their systems, to their blood units, and so on. So we can work on those integrations together.
In a very long-winded answer to your question, your very simple question.
Are we good?
Any other questions at all? Thank you very much.
Thank you, guys.
Okay, thank you both. And that was a really nice demo, actually. It worked really well, didn't it?
Yeah.
It's always seamless, right? Which is what you want to show when you're showing a phone, etc.
Well, yeah, absolutely. If it had all gone wrong, it wouldn't have been very good.
No one would have got comment. Yeah. So obviously I work with Vodafone as ambassador, so I do a lot of stuff around that, think about how you're going to get to some trust and things. So it's been a great couple of days, guys. Thank you all for still being here at the end of 2 days. I think we've covered a lot of work, and I think we've just missed window of the pandemic. I was worried over the weekend thinking, wow, the new variant, are we going to make it over the next couple of days? Is Boris going to close us down and we're going to be at home virtually? But I think we just made that window safely. That's been great. A few thanks, really, I think, at the end of this. I know people are outside are waiting to go home and stuff. But organising a conference like this takes a big team. We have conference makers, students, trainees, interns, medical students. We had student from Cambridge Medical School yesterday who was on stage with me for a whole day. He's got finals tomorrow, right? So, but he wanted to come and help us out despite having finals at Cambridge. So that's kind of a commitment that we've had from many people across the year. The other thing, of course, is around the AV. The future is around hybrid models of conference. You can't imagine how difficult it is. Think about live setting, all the people from around the world joining us in real time across different platforms to ensure they're there on time, ready, so it's seamless. And last 2 days, it's been phenomenal. I was in Dubai at GITEX giving a keynote last October. They spent millions of dollars. The hundreds of people running around the World Trade Center trying to fix this problem. How do you create real-time, different time zone stuff? And our team of 2 here, essentially, Scott's gone, have recreated the same thing that Dubai spent 100 million on, trying to create their platform for working. I'm sorry about that. I mean, apologies. Go to Dubai, they pay loads of money. And so I'm just saying that that's incredible. I was really apprehensive about how that would work. People are still discovering what conference can look like in 2022. We don't know. This is our vision of conferences. We think we've done the right job. We had 1,500 people come yesterday, 1,000 today, and over 400 or 500 on virtual platforms. So it's really interesting. So you may not think you're speaking to anybody here, but actually speaking to the live audience out there. So it's a really strange concept. We won't expect packed audiences anymore in the future. It's going to change. So that's kind of what we've been trying to figure out as Giant, and we've been really happy with that. So thank you for coming. There's networking, I think, downstairs, so feel free. I think there's some drinks in some pub around the corner. Just go and ask the Giant crowd, and please come join us, please, half an hour or so before you go home. And hopefully we'll see you next week. But thanks to the AV team. Can we have a round of applause for our AV team? Come on. Great job, really good. I will see you guys hopefully next year or around the system, right? Thank you.